It's my honor to be here to speak to you this afternoon about developmental issues and child maltreatment in this context of refugee health. I think, as Mally stated, we've come a long way, and our kids have come a long way in lots of ways in refugee health and in settlement. We also have good guidelines in infectious disease and tropical medicine and all those things that as some clinicians get really excited about. But I think we wanted to focus today on the lesser considered issues, those of mental health, those of complex medical conditions that are hard to navigate, and of child development and maltreatment. But I urge you, because they're not relevant to everyone, and I totally recognize that, to look at them as examples where intersectionality or multidisciplinary care, or whatever your term of choice is super important, not just within our health system, which is siloed and fragmented itself, but within health system, within society, within our social services, within our education services, and all of those complexities. So to start, like many before me, a few cases. Hassan, I'll tell you my story of Hassan, and you'll meet Hassan and his mum at the end in a video at their request. So I first met Hassan when he was 4, and he had arrived, born in Somalia, had lived all his life in a Kenyan refugee camp along with his siblings, and as all good things happen, it was Friday at 10 o'clock, of course, and he came to the emergency room with pruritic skin lesions. But more importantly, to me, or more interestingly perhaps to me at the time, he had obvious developmental impairments, spastic quadriplegia essentially. What became clear was cerebral palsy. He wasn't able to sit, he was nonverbal. He seemed uncomfortable, at least. And the history was provided by limited translation from his 14-year-old brother, who's become a very impressive ally and a nurse now. But more importantly, as we kept digging, it was clear eventually that this was actually his 9th visit to a healthcare provider in our city, 7 different locations. That's all the institutions in my city, in the first 3 months in Canada. This was a mum who spoke 2 words of English, was a single mum, had 3 kids. It was winter in Hamilton, and she'd gotten herself to 7 locations. And the reason that became clear was that she was told in the Kenyan refugee camp that if you go to Canada, the doctor will fix his brain. And so the next few years evolved an ongoing discussion and some time apart, I would say. I lost him to follow-up for a while, where Mum was looking for the cure. And we could not provide a cure, but we could provide quality of life and the social supports and all the other things around it. Another little man I met, a beautiful little guy, wheeled down the hall, looking somewhat like this stock photo, in our very grassroots, basic refugee clinic. And the family had 3 children. They were Karen, had lived all their lives, more than a decade, in a Thai refugee camp. And the settlement worker says to me as he's being wheeled down the hall in a stroller, "They're very excited to meet you." "Oh, why is that? What are their concerns?" "Oh, they have no concerns at all. They're just really excited to meet a doctor because none of their children have ever met a doctor before. They're kind of curious why you want to see them." And I said, "Are you sure they don't have any concerns?" He's 3. No concerns. He wasn't walking or talking, which is a little late. And as I tried to gently explain that his facial features, although they looked a little like his mother's and father's, but they also had some features that looked like he might have had an extra chromosome called Down syndrome. And his mother said, "Oh yes, he doesn't really walk or talk like his siblings did. He has polio." So after a lot of discussion, I gathered that the comparison was to a handful of other children in the camp that they got to know who also had difficulty moving or mobilizing. And the recognized experience locally for them was that people who have polio can't move as well or can't use their legs. And so that must be the explanation. They weren't really very interested in my thought about why maybe it was more challenging for him to learn to walk. But they were quite happy to have seen a doctor. So these cases were early in my clinical practice, amongst many, many others, and they highlighted for me, as many people this morning have, around the barriers to care for refugee families, amongst many, many other lessons. But I wanted to highlight for you the 2 that sort of stick out to me and perhaps are the most sticky or challenging to address. Those of cultural differences, and those of the unpreparedness of us as the host country the host health system, the host professionals, whichever term you wish. And so there's those extrinsic barriers around the outside and the intrinsic ones, but really this is obviously a different experience for every family, and we have to recognize it's not all on them, it's also on us. So to go into developmental disabilities a little, I like this definition somewhat. It focuses on the participation or the function of folks within a society. I don't know about the acceptance in society, but to highlight that 10 to 20% of individuals have some kind of developmental impairment, whether that be sensory, hearing or vision, intellectual, some physical disabilities that limit their participation or communication. But refugee children, as in the theme of all of today, are at higher risk for many reasons, most due to the environment they come from, but also perpetuated often by their migration process or their settlement with us. Risk of infection, I see a lot of children with having had cerebral malaria, partially or late treated meningitis, TB and HIV, also exposures to trauma, both from conflict and war, and as well as physical traumas. Nutritional issues, both in the pregnant mom as well as in them, including lead toxicity and B12. Genetic mutations related often to consanguinity that align with some populations. And even the necessity of the family's priorities to focus on safety and survival rather than developmental stimulation that many of our parents focus on. So I like this concept from UNICEF, and if we look at sort of the promotion of disability and how children are included, I think we need to consider that refugee children, in fact, almost have a double settlement challenge. They have the settlement of arriving in a new country, a new climate, settling into home and language and school. But for many of these children with developmental disabilities or any disabilities, they haven't ever been to school, despite them being late school age or teens. Certainly, I've experienced many of those children in our practice, partly because of the cultural difference in terms of acceptability or just the access to schooling and the value of that. So we need to keep in mind that rather than to generalize sort of ideas of culture, that there's variable adherence within any group to certain norms, but we all have similarities of valuing family, of all parents wanting the best for their children. And so this transition from perhaps their children being excluded from many things to very much included and interested in function may come in variable ways for families. The WHO highlighted this by the International Classification of Functioning Disability and Health, or known as ICF, in 2001. And I think I like it because it de-emphasizes the health condition and it re-emphasizes the function and the participation in our broader society. The reason I put it within this context is that it helps to emphasize that our health system is a very small part of these children's migration story and settlement and successful function. We can take very small credit as well for helping along their health conditions. So a friend like Hassan, his family has moved 4 times between 4 different home care regions, schools, had to resettle each of those times. And I can't imagine the challenges in navigating all of those systems to have the resources he needs to function properly. And yet his mother's been able to do it. My esteemed colleagues at McMaster have adapted this to childhood disability. Peter Rosenbaum and Jan Willem Gorter call it the F words in child disability, which perhaps sticks a little better than the ICF, but emphasizes those friends, family, and fun. I was asked to speak about child maltreatment in refugees. It's very challenging to address very quickly. I think the key parts here are that there's no evidence. There's in a very well-done recent systematic review to suggest that refugees are at higher risk or certainly have higher child maltreatment. They do not. They have the same as the general population. However, they are ethnic minorities at least, are over-screened for child maltreatment by 8 times and over-represented in our child welfare systems. Lots of proposed reasons for this. Some made claim there's harsher discipline practices among some populations or families or cultural groups. But I would challenge us to think about the multiple other reasons: the poverty, the related social risks of the migration, the detention, the things we do as Canadians or health providers, the biases of the professionals involved in decision-making about separating children from their families for child welfare reasons. These are not easy decisions. They are very challenging, but we all have biases. The lack of cultural competence, but also more appropriate resources, the time to spend, the funding to spend the necessary time to unravel all the layers. So the CMAJ guidelines you've heard referred to multiple times recommend against routine screening for clinicians, but being alert to signs and symptoms, being welcoming, and creating a safe place for disclosure is where I'll leave it. You can imagine then that things like, this is a picture of the results of coining, a traditional healing practice with oil rubbed on a coin and rubbed along skin, may create some skin lesions, such as bruising, may be misconstrued very easily for a child being shaken or intentionally harmed. It takes a lot of time and cultural understanding to unravel those components, similar to a cupping procedure that you may have heard of recently from some Olympians. So I end with, what can we do? As health professionals, I look to you as health leaders with a lot more clout than I have, to look at, perhaps as one minor part, looking at your own health system, your own institution. How do you process children, families who have no insurance, have IFH, which is challenging, or are underinsured? Is there interpretation services at every level of contact? For a visit is one thing, for a reminder call, for a follow-up phone call. I still get a letter in the mail in very complex English telling me about a specialist appointment 2 years from now. What do families who don't speak English do with that? Around our resources, around coordinating appointments, challenging at the best of times for those of us who understand the system, let alone someone who has gone to 9 different health providers to find a cure. And I encourage you to keep it in your research and educational priorities and in your engagements with community partnerships. I'm heartened as a program director to see in our new competency-based medical education at Royal College level that cultural competence and caring for new Canadians, perhaps due to some pushing, is in there and is coming. But it needs to be about across all health disciplines. So I leave the last words. Perhaps you can start it with Hassan and his mother Ayan and Ayan's brother.
So we have the Canada, and we need to help other kids come from newcomer, like Hassan. Mm-hmm. I was a single mom when I came to Canada.
Yes.
Yeah. So Hassan, he get big help here and big change. He's laughing now. And he's a very smart boy, and he teach everybody what's the life look like.
Mm-hmm. My apologies for my technical videography abilities in my clinic. Thank you very much.